Good morning, everyone. I'm going to go ahead and get started. Thank you all for joining. I hope everyone is doing well. I'm going to remind people to sign in on the chat. That way we can keep track of who all has been here and make sure everybody gets what they're looking for. I also would remind people we do record these sessions, and the recordings will be put up on the AHI website, usually within a week or so, along with the PowerPoint and any other documents people might want access to. So for today's agenda, we are continuing some of our discussions around the quality metrics. Specifically, this time we'll look at hypertension and A1C. Just a few reminders about PCMH. Have you started your tracker grid? It is a new year now, so people should be looking at their tracker grid, filling in what they know, starting to plan when they have to start looking at reports or pulling reports. As well, I'll remind people in general, it is a new year. The forever coding and the annual wellness visits need to be addressed as well. We always try to encourage people to get that into their regularly scheduled annual wellness visit, that they look at the forever coding and make sure they're coding those so they can get that credit as well. We are going to be talking about the electronic quality or clinical quality measures today, so I'm not going to spend a lot of time here on the PCMH. If anyone has any questions, I'll give you a minute or so if you want to ask anything about it. Okay. And the last reminder I will make, because I did get an email or two about it, is that some people are starting to get the notifications that they're due for recognition again, and their annual recognition is due, and they just submitted in November. Again, I remind people, we had the extension last year because of the COVID, and so everybody got pushed to November, but your dates did not get pushed. So you're still being held to the same original anniversary date on which you initially were recognized on. So again, some of you are starting to see it's time to look at things. And again, you can reach out to myself or anyone at the ACO if you need some help with some of this stuff. Brenda, myself, I think you have our email addresses, and again, they're attached here, so don't hesitate if you have questions. Okay. Ruth Ann Craven has again provided us with some phenomenal slides, so I'm going to turn this over to her and let her present. Good morning, Ruth Ann.
Good morning. All right. So I'm going to talk today about the ECQMs for controlling hypertension and blood sugar poor control. So next slide, please. So we'll go into the specifications a little bit. I find it helpful to kind of revisit those every once in a while to make sure it's fresh in my mind. We'll talk about some tools that HCSCN offers to help you address hypertension and blood sugar control. And we'll talk a little bit about documentation and information sharing, and then wrap it up with some tips to improve performance. So next slide, please. And the next. Okay, so we'll start out with controlling high blood pressure. This ECQM is looking at the percent of patients ages 18 to 85 years of age who had a diagnosis of hypertension either in the current measurement year, so the current calendar year, or in the previous year. And then it looks to make sure that their most recent blood pressure was adequately controlled, which is defined as less than 140/90 during the measurement period. So next slide, please. There are exclusions for this measure. I think we always remember that end-stage renal disease patients or those on dialysis are excluded, as well as women who are pregnant, patients in hospice care, But there's also exclusions for patients 66 years of age or older who are in long-term institutionalized care. So for example, living in a skilled nursing facility for at least 90 days, and patients 66 years of age and older who with advanced illness and frailty. So the next slide, please. To be compliant with this, the blood pressure reading needs to be performed by a clinician or by a remote monitoring device. And you don't take blood pressure readings during an acute inpatient stay or an inpatient visit, or any that were on the same day as a diagnostic test or procedure that required a change in diet or medication, either on the day or one day before the test, with the exception of fasting blood tests. And you don't include it if it's reported by or taken by the patient or the member. However, this does qualify for telehealth. So I believe what they mean by that is it needs to be a digital device that reports it. The patient can't manually take their blood pressure for it to be eligible. So next slide, please. So if there's no blood pressure recorded during the measurement period, it's assumed the patient's blood pressure is not controlled. And if there are multiple blood pressure readings on the same day, you use the lowest reading as the most recent blood pressure. So next slide. Okay, so an overview of the hemoglobin A1C poor control measure. I actually have trouble with this one, remembering that lower is better. So it's looking at which diabetic patient's blood sugar is not in control. It looks at, again, adults ages 18 to 75 years of age who have been diagnosed with diabetes and whose A1C is greater than 9%. So next slide, please. The exclusions for this are also patients in hospice care, the patients age 66 years of age and older who are in long-term institutionalized care for more than 90 days, and older patients with advanced illness and frailty. So next slide, please. Okay, so to fall into the numerator for this, it looks at the most recent A1C test, and if the level is greater than 9%, so it's out of control, or it's missing, or there hasn't been an A1C test, then the patient would be in the numerator for this measure. If the test result is in the medical record, the test can be used. So you don't have to necessarily do it at your office. You just need to get the result and document it in your medical record. Only patients with a diagnosis of type 1 or type 2 diabetes should be included. If they have a secondary diagnosis of diabetes, they would be excluded. So next slide, please. All right, so now let's talk about the tools that Ecqi offers. So we've talked a lot about the patient record snapshot. We have the quality indicators section, and we do highlight for you any patients that are hypertensive that their blood pressure is controlled or not controlled, and diabetic patients if they've had the A1C test or not in the measurement year. And we also have the quality reports. So you have the gap list and the compliant list, as well as the quality measure list that you can work with. I've provided for you some workflows that I've done for other practices to kind of walk you through what you might do at your office, having your care coordinators or care managers look through things. But really, from my perspective, the best practice is pre-visit planning. Make sure that you are checking these things on your hypertensive and diabetic patients before every visit. So next slide, please. And also I gave you a workflow where if you get a gap list from an insurance company, you can check Ecqi, and it's possible that that gap has already been closed, and kind of walks you through the steps to obtain that documentation and get that to your health plan. So next slide. So it's really the same for the A1C test. We have quality measures for diabetics who need their lab tests. Similar workflows as far as closing the gaps in care. And then the next slide. And again, finding that documentation if someone is on your gap list who has had their blood test done. And a good resource is the National Diabetes Prevention Program, which I know a lot of organizations in your area are working on. So next slide. Okay, documentation and information sharing. We've heard this many times before. I can't emphasize it enough. It's really important to document this information in structured data fields. So check with your EHR vendor regarding how to document these to be sure that these screenings and the results, so the blood pressure readings and the A1C results are shared with the Health Information Network and they qualify on your ECQM reporting. And then document this information in standard codes. So there's level 2 CPT codes, which would show in the procedures section of the portal. LOINC codes are in the lab results section, as well as the history section of the portal. And SNOMED codes would appear in the conditions section of the portal. So next slide, please. Okay, so this gives you a screenshot from our portal and kind of points out the important sections on the patient record snapshot. So if someone's doing pre-visit planning, you look first at those quality indicators section. If you're trying to close the gaps in care for the blood pressure, check the physical exam section. That will show you the blood pressure readings that have been documented for this patient at any physician office. So for example, maybe their most recent blood pressure where it was controlled was at the cardiologist's office and not your office. You could find the documentation there. And then the lab results for your A1C are, if it's recent, it will be right there on the snapshot. If it's historical, you could get it from the tab, the lab results tab. So next slide, please. Okay, this is just for your reference. I provided you with a list of the most common codes that we see for blood pressure and A1C levels. So these are the CPT2 codes. The next slide. LOINC codes. I didn't even know we had LOINC codes for blood pressure, so that's interesting. Next slide. And the SNOMED codes. And I don't expect anybody to memorize SNOMED codes, but it's just good to know that they do exist. Next slide, please. All right, so let's talk about some tips. Only those patients who have provided consent for you to view their healthcare information will appear on HCSCS's quality reports. So I always like to remind you to consider waiting room displays or exam room signage to kind of encourage your patients to consent for you to access their information. And that will allow you to provide more coordinated care with other organizations outside your office. Completing pre-visit planning to identify all the gaps and then periodically review HCSCS's quality reports. Consider how telehealth visits can close gaps for these measures, and I provided you with the hyperlink to the most recent guidance for the use of telehealth for ECQMs. For diabetics, coordinate lab testing prior to the office visit so the results can be reviewed and treatment plans updated as needed. So next slide. And throughout the year, you might need to repeat abnormal lab tests in order to improve. So is their A1C at goal? And if not, maybe they need to come back in 3 months and have another test and you can see if they've improved. And repeat blood pressure readings during the office visit if the initial reading is high. And monitor their blood pressure status at each visit and adjust their medications as needed for control throughout the year. And diabetic patients and hypertensive patients are probably high-risk patients that are under care management. So remind your care managers to communicate with these patients throughout the year to make sure that all their tests are completed and that they're staying on top of what they need to have done. And important with that is to problem solve to resolve any barriers to getting care. So they might have difficulty getting to the lab. They might not have access to their medications. They might not be able to afford their medications and so on. So it's important to address those barriers as well. So next slide. Educate patients on evidence-based standards of care and lifestyle changes. So offering handouts and tools on self-management support. Some practices enter into patient compacts with treatment goals and provide tangible reminders of the care needed. So the American Diabetes Association has some free resources, as well as the Center for Disease Control's National Diabetes Prevention Program has some free curriculum and handouts for patients. And lastly, promote the use of the patient portal so patients can be messaged frequent reminders about care or sent disease-specific newsletters about evidence-based care that's recommended. So next slide. All right, does anybody have any questions about the ECQMs?
Ruth Ann, this is Sandy at Dr. Ryder's office. I just wanted to make note that on many of your slides, I was not able to read what you had in like this really pale colored font that was over to the left side of the slide, especially when you said like, here are some CPT2 codes for the blood pressure. I could barely make those out. It was like in a font that was not showing up well on the screen.
We'll take care of that. We'll darken that up for you all. Thank you for that feedback, though. That's very helpful. And we post this up on the website too, as well. We'll send it around when we get everything done. We kind of put everything to the meeting invite, so you'll get it as well in an email. Thank you, Sandy.
This is Abe at Adirondack Pediatrics. I have a question about the diabetic measure and telehealth. We've seen most of our patients are managed by endocrinology, being a pediatric practice. And we've seen over the winter that because most of them are doing their visits with telemedicine, and nowadays with these continuous monitoring, blood sugar monitoring devices that are available, we've seen some notes come back where instead of doing an actual blood draw for an A1C, they're doing a telemedicine visit, and they're noting that the A1C is estimated based on the data from the download off their continuous device. Do you know if at some point that's going to be considered acceptable, if that becomes a standard practice, especially if like telemedicine is kind of becoming a big thing? I've asked other people, but nobody's really has an answer, and I don't know if it's something that's just starting to happen, or, I mean, the devices are pretty accurate. Being a diabetic myself, I can tell you that they match up pretty closely.
I have not heard yet if they've made a decision, but I do know that the issue has been raised, and like remote patient monitoring for blood pressure, they would like to include remote patient monitoring for the A1C measure, but I don't know that any decision has been made about that yet.
Okay, so we should probably then order an A1C ourselves for those patients.
For this year, yes.
Okay.
Brenda, do you have any additional information about that?
No, I have a question out for that, and I'm glad that Abe brought it up because I'll resend my request again because I haven't, and you know, I agree that for 2021 I would just order the A1C until we can get further clarification. But you know, certainly you know, we've got time, and we'll get that back out to you. You know, if we get notification sooner.
Thanks, Abe, for that. Anyone else have any questions about either hypertension or A1C?
Hi, good morning. It's Rebecca with North Winds.
Good morning, Rebecca.
Good morning. I do have a question around the hypertension, so the blood pressure numerator compliance. You had noted that it needs to be performed by a clinician or remote monitoring device. As we start to engage in these discussions with our North Winds providers, and I can think of, you know, our 2 cases specifically with inpatient SUD treatment, where they're doing a kind of overall physical and including this, and we're talking about documenting appropriately so it can be caught in the record. But can you define clinician? You know, can this be an LCSW that's doing an intake, et cetera, or does it need to be a physician level?
I don't believe it needs to be a physician level because nurses do it and LPNs do it when they room patients at the physician office. I think it just needs to be clinical within their scope of practice.
Okay, perfect. Thank you.
I would just call out though, Rebecca, you had mentioned about the inpatient. This is making sure you're taking it in the office, or to your point, when they're meeting with a provider, and I use that term very loosely. So the inpatient documentation of hypertension does not meet the requirement for the hypertensive. It has to be a follow-up, basically.
Got it. Yeah. So in an office
In the
visit or
office
follow-up
setting,
visit.
or
Yep.
during a counseling session, maybe they're taking it then too. I mean, wherever they might be taking it, as long as it's not the inpatient, it really does need to be some sort of an outpatient or follow-up kind of visit.
Okay. Thank you for the clarification.
Anyone else with questions, comments, feedback? Okay, don't hesitate as you're thinking this through to raise your hand and raise the questions. I'm going to go ahead. Both myself and Brenda will be kind of tag teaming this section. I'm going to let Brenda start off just looking at some of the metrics.
So back in January, for all of the adult practices, we had requested that you run the 2020 performance for the 3 electronic clinical quality measures that actually Ruth Ann has been so helpful to cover the last couple of meetings. And for our quality improvement work group to actually make a decision on how we would proceed with our reporting to CMS for 2021. In 2022, the ACO has to report on these 3 clinical quality measures electronically. So we have the option for 2021 to actually utilize this process. And so we wanted to assess kind of where we were and how well we were capturing this data. And to be quite honest, I think we were pleasantly surprised that many of our practices, that we can see performance-wise that, when we look at this graph on poor A1C control, that 55.97%, we know that practice, that there's issues behind the scenes that need to be worked on, whether, A1Cs are being done, they're not put in the structured data field. How are things being sent? Are we capturing that with CPT2 codes when claims are being sent in? How is that being captured in the EMR? So really, the work group actually looked at the performance, and certainly when you look at where these measures lie, in our overall performance, and this is without remediation, without any work that's really been put into really focusing on the measurement this way, because the ACO for all of our practices since 2014, when it comes to MIPS, the ACO would report the quality, and that would certainly that would suffice for the practices not having to send to MIPS. So you can see that with this performance, we actually ended up at decile 7, which equates to the 60th percentile. So that in all honesty, what the right now, what Medicare shared savings, and I don't have the final 2021 because CMS is really looking at 2020 to close out 2020 and to move on. So to get some of these answers right now, we're kind of in a holding pattern until March 31st when they close 2020. And, they're really looking that we report at the 30th percentile in order to receive full shared savings in the Medicare shared savings world. So currently, for this measure, and if you can go to the next slide, Luann, for controlling hypertension, we are actually in the 60th percentile, and which is really great work. But again, when we start looking at some of these lower numbers and our percentages, we know that there's some remediation that has to happen. And again, that's really, a lot of the work may have to be done directly with your EMR vendor, and certainly we'll get into that a little bit later. The next slide is showing our overall performance for depression screening. And I have to say, I was really pleasantly surprised with this one to see, where we were with this measurement, because I know historically looking at claims data, since it is one of our commercial measures as well, when we get any of the data from them showing us our performance, I can say, I think tops we've shown, we've kind of maxed out at 10% through claims. So we know that things through the claims world is not, you know, it's an area that we need to work on, but certainly through the, you know, ECQMs, we did really well, and we're in the 70th percentile for completion. So again, I think there's work that can be done, and certainly we can get into that, you know, when Luann pulls up, you know, the next slide and we walk through that. But I think it's great work, and I know that the quality improvement work group, there will be an email coming out this morning to all of you that will include this timeline. And again, you know, certainly the remediation efforts that have to, you know, happen. But the quality improvement work group does want to move forward with this, and hopefully for 2021, we will submit electronically. Luann, you're on mute.
Well, that was nice. You got a reprieve from me talking. I pulled up the Excel spreadsheet because it's just easier to view this way. And we will send this out to you all after the meeting. What we have done is we've kind of pulled together a little project plan, template, remediation kind of a thing, just to kind of give you something to go through and look at where you're at in relationship to being prepared to do the electronic clinical quality metrics submission. So I would say, first off, this is just our first, maybe second draft of this. So please, if you have any suggestions, send them on back to me and we can add those. If you have other tools that you're using to try to look at your own preparedness, we certainly would welcome those and share them with others. But basically what we've said is, you know, starting off up top, it's always a good idea to identify those people that are going to be like the primary lead for the process. Again, who's going to be that, you know, steering committee or stakeholder or whatnot. And again, depending on your size, it might be all the same person, or it could be a couple people. But we do suggest that through your quality initiatives, you actually do spend some time looking at this. The three metrics metrics that we're going to be submitting for are here, and then we're also providing the resources for that. Some basic stuff of just reviewing your measures, making sure you know that there's structured field behind it, that it's getting populated the correct way. If there's any workflows that need to be adjusted or impacted, that should be something you would take a look at. Are you using the right codes to make sure that you're capturing this? Are you reviewing your reports with some regularity? And if you don't have those reports, what are you using? Again, I'll mention, you know, the Hixney reports can do the same thing for you. You can pull up and see where you're at with gaps for A1C and or hypertension. So those are another source for you to be able to look at. Looking at your best practice workflow for these, where are you capturing the data? As Ruth Ann mentioned, are you reviewing this in your pre-visit planning? Do you have those reports defined? Is the process clear of how you're going to run those reports with what kind of regularity? Are you meeting the requirements that we've set here globally? And I think the biggest thing, and we're going to talk a little bit about this, is working with your EMR vendor to make sure that they have support for you to submit electronically. Many of the vendors do now submit or have the capabilities to do some ECQM submission. And so I would strongly recommend you have a discussion with them. And if you're still having struggles, by all means, come back to myself or Brenda. We are trying to work with some of the vendors ourselves to see if we can't get them to get on board and or come and present and kind of give people helpful hints about what you need to be doing, what things you need to be checking. I think the other piece too, and this was called out at the quality committee, because this quality committee also took a look at this, the ACO quality committee, was that it's important to make sure we do some education and communication to all staff so they understand what the workflow is, why they're having to do it this particular way, making sure they're documenting the blood pressure in the right spot, making sure the A1C is being looked at and present and accounted for? Did you get that lab result? Doesn't have to be yours, doesn't have to be something you did, but you have to make sure you see that. Certainly as well, there is some opportunity here, and this kind of goes hand in hand with some of the work efforts you have for those that are members of the ACO around your citizenship criteria, attending the practice transformation work group itself, the quality work group if you have it, and then any of the ACO webinars. We're certainly going to be presenting information along these lines, and it counts again for your citizenship as well as for your NCQA work efforts as you're submitting for your PCMA3 recognition, that you've provided this education and you're reviewing this at your quality meetings. And then, the ongoing implementation and evaluation, making sure you've got this information, you're using the same information for your quality metrics. And again, when you're talking about looking at that tracker for the PCMH, have you identified what quality metrics you're going to be tracking? These are perfect ones. You got 3 of them right there to go. Monitoring that monthly performance, making sure the reports are meeting the compliance. We also have, some reports that we've been sending out through the ACO, and we'll continue to do that. It's at aggregate provider level, but again, we'll be looking forward to be sending those out to you on a regular basis. And then last, by no means least, we did provide some resources. There's the ECQI Resource Center. And then just for people's information as well, we provided a couple of articles that talk to the ECQM and the benefit of doing these kinds of things. And again, hopefully we've picked some good journals that are reputable that you can provide as part of your education to your practices as well. I think the physicians might find some of this. I did try to pick out some evidence-based research articles as well. So hopefully that'll be a help for them. The other areas here we have called out the Frailty Codes. Frailty Codes are a big one, and I know we'll continue to talk about Frailty Codes, but we did provide you with a list of them, if you will, and I'm going to ask Brenda to do a little plug for the Frailty piece.
So thanks, Luann. One of the things that when we were doing data abstraction for 2020, the Frailty Codes are hard to, looking at a chart and doing the actual abstraction from the chart, a little bit difficult, but the Frailty Codes are really have been set out there for everybody that's on the phone that has been doing data abstraction for the ACO for the last several years. Part of it, we've seen a gradual change from CMS and HEDIS, really looking at the appropriateness of the measures that we're requesting information data on for these patients. And they've heard a lot of feedback. We first noted back in 2014, that was actually the first year that we joined, and we reported on in 2014 that hospice was eliminated back then. And then as time's has gone on, the difficulty of doing data abstraction and people are in nursing homes, they started excluding people who are in long-term care because the appropriateness of people getting mammos, colos, depending upon what their illness or what was happening, they said, that's not really appropriate. And then we are managing people longer at home. And what would qualify people if people are in, I think if you go down a little bit further, Luann, there's
Sure.
a diagnosis codes that are in there. So if somebody has, they have cancer, they're in treatment, are they appropriate at this time to be evaluated, to have all of these other, what are their life goals? Really focusing on ensuring that the person has the appropriate resources. So really, as we move forward, you're going to see CMS and HEDIS really starting to look at what is happening with the patient and are we supporting the patient in the best way. So they're going to start looking at measures that support, the transitions of care codes. They're going to be looking at that coordinated care effort and how we support those people and looking at readmissions and those types of measures for these individuals that would be excluded from this measure set. So this is something as we go through, and we're going to be talking at the next quality improvement work group about this. Certainly, these are codes that we support that will remove people from the denominator inclusion. This is stuff that should be in your EMR. Your vendor should already have this built in, that as these codes are utilized by the providers, they will remove them. And actually it's A1C, poor control, hypertension, and breast cancer screening, and colorectal cancer screening are 4 of them that fall into this, this criteria will exclude people from the measure. One of the things that, we will be, I want to point out too, is the reporting is not at the provider level to CMS. The ACO will need to aggregate your data to submit in 2022 for 21. So there are certain file formats. Certainly we'll build out, because as Luann and I was talking, it was all these things that I think we know in the back of our minds how we need it, and we'll have to update the tracker with the type of file that we will need from your practice. Certainly, from the practice side, when we're looking at it, and as you're evaluating these, running your quarterly or monthly, however you want to do it, you can run it at the TIN level so you can see how your performance is overall, but then you're really going to want to get into the nitty-gritty of pulling them at the provider level to see who is it that needs more supports, are they documenting correctly, or, is there, I know for some of our practices here in the North that we have a lot of providers that have their own templates. So if the template isn't mapped correctly, and the provider's documenting, he's collecting it, but if it's not in the structured data field, or if it's a different place in the template and it's not flowing, that you're able to monitor that performance. And so I go back to like the A1Cs, that practice that has an A1C at 59, poor control at almost 60%, can almost guarantee that that's a mapping issue that's occurring there. So, those are the types of things that we'll be looking at, and certainly for us to help. As I look at the frailty codes, and I think many of you who saw, there's a lot of information there around falls. And we talk about your work around NCQA. Fall risk is a screening that we do for, all of our Medicare population. You're screening at your annual wellness visits. And if somebody has a fall, then, thinking about how can we tie in that fall risk assessment, and if they have a history of falls, utilizing the Z code that's here to ensure that you capture that, because that would help bring this into the fold to be able to capture that. So, those are some of the things that we can start working on and thinking about. It's a great quality improvement, initiative to run within your practice, because you're already screening. So how do we tie some of those codes to it so that we're capturing this information as we move forward? And, we really want to help tie in what you're doing every day to help support this measurement, but also to, meet other criteria and things that you have to do this year. I don't know if anybody has any questions or comments.
Brenda, this is
Yes.
Sandy again at Dr. Ryder's office. To be perfectly honest, right this second, I feel very overwhelmed based on, it seems like there's quite a bit here that we haven't obviously been tracking or doing, and on top of what we have been doing for NCQA. Will we be able to get some help from somebody?
So, certainly, looking around, when we're looking at these ECQMs, working with Athena to make sure that those things are moving forward correctly, certainly Luann and I can, help. I think if I remember correctly, and I can't off the top of my head, I'd have to go back to look at your specific performance. I think those are things that we can certainly, help guide. But again, making sure that the measurement, that that the reporting capability within your EMR has been updated with that Athena, that you have all of those, and then being able to run those reports to really see where is it that those, if it's not aligned, or if the mapping behind the scenes is not occurring, it doesn't mean that you guys aren't doing it. It's the mapping that may have to be redone. And of course, you're talking to somebody who, you all understand I'm not certainly the most technically, the most technical help when we start talking mapping, but I have to say that Luann and I met with MedEnt, and MedEnt, certainly for many of you that do have MedEnt that's on this call, we saw the mapping for 2021s that's there. They are very open to be working with anybody to help do that. And I think, as part of, your EMR, your vendor, this is part of what they have to do to remain in compliance, because they're attesting every year when they have their 2015 that they have to, that certification, that they're attesting that they meet the criteria for that, that recognition that they have. So again, those are things that we can certainly, talk through and work with you. And if you want, I'd be more than glad I can set up time to walk through that with you, Sandy.
Brenda, this
Yes.
is Erin from Hudson Headwaters. Can you hear me okay?
Yes, I can.
Perfect. Sandy and Brenda, I just wanted to let you know, so Hudson Headwaters does use Athena, and Sandy, I'm more than happy to talk to you offline if you'd like, but I did want to make you aware that if you go into the purple strip on the very top of Athena when you're logged in under the quality measures, if you go there, under there, there's a drop down that says ECQM data, and you are able to pull really any measure that is live in your EMR. So, Sandy, if you want to reach out to me, my name is Erin Dunn, and I'm sure Brenda can easily give you my email address. So I'm happy to walk you through that.
Great. Thank you, Erin, very much.
Thanks, Erin.
Sure.
And I'll just remind everyone, at any time, please reach out to me as well if you have questions and how to connect this. I agree, it seems overwhelming. You've already got one tracker, now you have another one, but I think if we can overlap these, this is just a subset of the bigger one where you're trying to make sure you're meeting those quality metrics for the PCMH. And so hopefully, focusing on this and having this in place sooner than later will be a help to you when you do have to go report to NCQA. Thank you, Erin, for offering up your time and expertise. That's really greatly appreciated. I can also provide any kind of context. Don't forget too, when you open up this particular invite, everyone's address should be showing up. And if it isn't, by all means, reach out to myself and I can help you get that.
I have a question. I'm sorry, this is Jackie from Nathan Latower. I have a couple of concerns, and not from what you told me, but because we're switching EMRs, and we have MedEnt, and I love MedEnt. MedEnt is my friend, but they're not going to be for long. And I just uncovered that they do support these things in a way that they're not required to on a specific level, that they do this because it's something that obviously they know that their customers need to be able to report on. Expanse is our other EMR that we are going live with in September. And I'm struggling because I'm finding out Expanse does not build this stuff like MedEnt does. Guess who gets to build that stuff? Me. So I have to be able to go into all of those requirements of what CMS has set aside to each of these measures, make sure that the appropriate data has been built or queries that can be then pulled. And I don't even get my data from Expanse. It goes to a third-party vendor called OneView.
So Jackie, I have a question. I mean, is your I mean, I don't know anything about Expanse. This is the first time I've heard of this vendor, but so in order for you to report NCQA, are they a certified vendor, a 2015, do they have that recognition?
Well, trust me, this is something that I'm now getting to the point of, because there's just so much. I mean, I have 80 providers on the outpatient side between specialty and primary care. And I have to build every single one of our quality metrics. I have to build them, the even the rules to be able to get the screens to auto score. I have to build it all. And now let me tell you, I am not an IT person. I am a nurse. So I have been building these things out and learning a whole lot more than I ever thought I would in my life. But I'm not seeing that. This is exactly one of my concerns. It's almost like they depend on that third party vendor to be considered the one with the certification. And I don't know if that's what qualifies us. But
Luann,
I don't even know how to ask these types of questions because I have never had to worry about it because MedDant takes care of it for me.
Yeah. I mean, again, if they define their process for meeting interoperability and being able to submit, quality reports and whatnot through that third party, that, at this point, I don't know that that's not acceptable. I understand the challenge it is because you don't have necessarily direct access to OneView. I know just a very skim of Expanse since Jackie kind of mentioned it to me a bit ago. But certainly, you can look fairly easily and see where they're at with their recognitions and some of those things. And quite frankly, attempting to push back a little bit, does OneView have the ability to assist in any way? And I don't know that answer yet, but Jackie, we can talk about some of that and see if we can't help. I do understand the challenges this kind of puts on you with your transition.
So we've come so far with all of this and done so much work to get us to where we're at. And we're essentially literally having to start it all over again to ensure that that data that we're getting when we are running these reports, that it's true data. And if not, having to tweak it to get us to what we're doing, but not getting credit for, like Brenda said, because we missed something in the build of the report. So I didn't know if anybody else has been, introduced to this wonderful new EMR other than myself, but it's a huge challenge. I'm going to guess that it is, but I just am not feeling it right now because the hospital uses Meditech, which Expanse is the newest version of Meditech, and they have MIPS reporting and they've been using OneView. So I don't know if the acute side has different requirements than the ambulatory side when it comes to some of this stuff, which is always possible because, but yeah.
Well, the measures are different.
Yeah.
The measures are different, but I think too, to the point, if they have the interoperability built in, it should be okay. And we just might have to reach out. You might have to reach out to OneView and see if you can get some support from them. Because again, if they're a vendor that's able to transmit, they already have to have some of that built as well. And it is a requirement. They have to be able to electronically transmit. Someone had a comment or a question?
Yeah, this is Angie Alice Hyde. I feel bad for you, Jackie, because if it's a Meditech product, you are going to have to build every little thing. So I'm sorry for you.
Some days I wonder like what we're paying for because it ain't their help.
Yeah. We back in 2008, we tried to implement at the time Meditech's outpatient system was called LSS. We have at the time we probably only had about maybe 6 practices, but we built it for one health center and scrapped the whole thing and went to Medit. So
Great. Thank you.
Okay, anybody else with any other comments about any of this? Again, you have my address, you have Brenda's, you have our phone numbers. Don't hesitate to reach out to us. As you're thinking of additional questions, I would encourage you to even send the questions along, and we can share those with everyone as we're all getting some more insight and gaining the understanding of how we're going to need to do this. So, don't be shy. Yeah. Hey, Lisa.
This is Lisa Tuggle from Adirondack Health. I know I had shared with Brenda previously, this is going to be an expensive undertaking for us. We were told by our vendor, ECW, it'll be upwards of $300 to $400 per provider for us to get the technical assistance to map this for the ECQMs. And, when you include, since we do report as a TIN, when you include all of our providers and specialists, much like I think it was Jackie that said, it's an expensive and timely undertaking. I don't know if the ACO has any support to help with that, but I know this wasn't something that was in our budget for the year coming off of COVID.
Okay. We'll take that information back and see if we can't talk amongst ourselves and maybe have further discussions with what they're looking at, because some of the EHRs are being pushed to do this, so I'm not quite sure why they're pushing that to their customers, but I guess that's what they do sometimes, and I'm aware of that.
Right. And what they're saying is, well, we have it available to you, but for you to have the support to show us how it's mapped and how we should be using it, that's what they're charging us for, the consulting.
So
to know how to use an existing system that's in place.
So Lisa, I'm sorry. I think one of the things, if you go into the resources that are on, I'll be sending out, there's a message that's coming out from the Quality Improvement Workgroup in a few minutes anyway. In there, when you click on those specific measures, those measures, it takes you right through. There's the SQL queries that are all there. I don't know if that's something, again, I know it would have to be mapped. I don't know who the team that you have at Adirondack Health, if that's some of the stuff that could be done. You know what I mean? That would be the support, the technical support that you could look at, and then it would be a minimal, because I don't understand the by provider. This is a measure that's across, it should be across all providers. And so it really is the map, you know what I mean? I guess I'm not sure I'm making sense, but in there is certainly the guidance and code for people that understand the measures. And I don't know if that's something that can be easily converted or used when you're looking at your EMR and how it's mapped from there. But
it's frustrating because, we got into this whole thing with MIPS and these ECQMs really defining us as practices. And it's a very overwhelming thing. And yes, each one of these ECQMs are tied to a separate quality measure that we already measure essentially or monitor. But the requirement for CMS in order to get credit for that is like astounding. Each year I take another measure and I try to break down why I'm not getting my patients into a numerator based on even with MedDent. And then have to go back to them to say, okay, why is it? Well, what is the problem here? Diabetic eye exams, for example, we use our health maintenance section of the history and add that in there because, of course, you can't say every eye exam you get from an eye doctor is a diabetic eye exam. It doesn't pull that data. So you have to be able to monitor that. And you can't put it in there as diabetic eye exam in the health maintenance. It has to very specifically state screening diabetic retinopathy. And there has to be a date that was attached to when that was done in order to get credit for that. It can't, even though we know that that's what it means and the providers do. So now all the data we've been putting in there in this way doesn't count. and except for going forward once you fix it. And that is the way that it is with every single ECQM here. And even though MedDent builds it like this, I still have to be able to monitor that data and know what's not good and what to do to fix it. So it's still, even with MedDent, as I said, it's still a lot of work.
Well, and, one of the things that I'm setting up too, Jackie, and not to, I will be meeting, New York State is certainly headed down this road of utilizing the ECQM. So, I mean, there's going to be more alignment, and not to add, anything. It's just that we know that this is the direction that we're headed. And certainly I think this is the provider education, that you've spoken to, and that we need to certainly pursue. This is great feedback for us, certainly on all levels, ACO and any of the other providers that are not part. It's just, this is where CMS is headed, and certainly, the state as well. And I think that's, through the work that we're doing with the HIE, with HICSNY, I think that's how we can align, our efforts. And certainly if we're utilizing the best tools that we have to be able to look at how we're collecting the data and what we're collecting, so that we can just, go on from there. But it is a lot of work, and I certainly, I feel for you making that switch, that's for sure.
And we'll be doing, as Brenda said, she's going to be conducting some more sessions around these topics. We certainly can, share information here and have another discussion about it at these meetings as we continue to move forward over the year and figure out where people are at. And I always encourage you to raise any questions you want here, or you want to have another session, or you want to have a specific thing, by all means. And if we can connect you with each other as well, so that you do have some resources that are kind of in the trenches, please let us know.
This is Angie again.
Yeah.
I'm sorry.
No. By all means.
Try and offer a constructive thought now, since I was a little bit negative before. I apologize. I really have started thinking lately, and I realize not everybody on this call is a hospital practice, but a few years ago on the hospital side, we implemented clinical documentation specialist. I'm not exactly sure what their title was, but essentially they were staff members who really reviewed the documentation from the hospital visit and made sure that we were coding for everything, and we were getting everything that we were doing. We were properly coding it and documenting it and all of that. I'm beginning to think that's what we need on the outpatient side. I think we don't necessarily know how many dollars are attached to a lot of these things, and there are. So that's something I'll be bringing up with my leadership, I think.
Yeah, no, Angie, I totally agree with you. And there is those clinical decision support specialists that they have in the hospital sides. We are seeing some creep into some of the larger practices that they utilize that same process to look at the outpatient documentation. It is very difficult though with the smaller practices, because there's usually one and the same person that's doing all of these things. But it might be worth sharing what some of the larger organizations are attempting to do around clinical documentation review, and at least giving people that kind of information that says, here's what we've attempted to do to try to figure out some of those pieces. So it might just be a worthwhile discussion, whether you're a hospital or a large practice or a small practice. You might be able to just glean some of those best practices that might help you all. So we'll put that on a list here and see if we can't bring up something about that.
Thanks, Luann.
Absolutely. I don't want anybody to feel like they have to jump off we certainly can stay on for a few more minutes, but I do recognize we've hit the top of the hour. I just want to remind you to do all that sign in. But please, if you have other questions and you have time, we're here for you right now if you still want to talk about things.
You know, and Angie, on your note, and just this is another, I think some of the stuff that the ACO is starting to look at, you know, from our standpoint, is looking at some of the missed opportunities. You're looking around the coding aspect, you know, as far as, but also the revenue opportunities. I think that's some of the stuff that we recently pulled, kind of looking at what the Empire program for us, you know, they're really looking at the chronic care management codes and things. So we were looking at opportunities there, but also the transitions of care. And I think that those are, you know, not only from the revenue side, you know, because we're all in a situation right now as to how, if we're doing all the follow-ups, right, when we're talking about transitions of care, the best practices, you're following up to 7 to 14 days, depending upon what's happening with the patient. And if we're not billing those transitions of care codes, you know, we're missing a revenue opportunity, but it's also that care, the coordination of care for those individuals as well, and identifying medication issues that are happening. And, you know I sound like a broken record, but again, you know, I think we're all at a point, COVID has put all of us in a situation of really rethinking, you know, what we're doing, how are we doing this, and what is in the best interest of our patients, but also of our organization. So the ACO is looking at that, and possibly, you know, and certainly we're looking for feedback from anybody, you know, that's on the call. What would be most helpful to you or your organization, you know, when we're thinking about missed opportunities? And, you know, again, missed opportunities around, as you spoke to, you know, if somebody's a diabetic and we're coding diabetes uncomplicated, but they have a pressure ulcer, or they have a wound, or they have, you know, nephropathy, and we're not catching that, we're also now not representing our patients and how sick they are. So again, I think it kind of all, you know, it all intertwines. And so how we can best support everybody is really, you know, another thing for us as well.
Thanks, Brenda.
Anyone else with any last thoughts or comments or questions? Okay. This was great. Thank you all for the feedback. Have a great day. If you think of anything additional, please send it forward and we'll try to share those thoughts and comments with everyone. And we'll be sending out the PowerPoint and the grid to you all after the meeting today. Thank you, everyone.
Thanks.
Thank you.